Welcome to the Pituitary Network Association's webinar with Dr. Lewis Blevins. My name is Linda Rio. I'm the Director of Education for the PNA, and I want to let those of you who've logged in already, thank you for your patience for waiting, and we still have some more people that are coming on board. I certainly want to appreciate all the presenters, including Dr. Blevins, and I will introduce him in just a minute. But first of all, I certainly want to acknowledge the amazing credentials of all the folks that have presented, and certainly want to let all of you know that you have the opportunity to not only hear Dr. Blevins here today, but to be able to ask him specific questions, which is a wonderful opportunity for people to live be able to get in touch just by typing in some questions, which I, at the end of the presentation today, will forward to Dr. Blevins so that he can respond in as much time as we have here today. Hopefully we'll get to as many as possible. It's so important to be able to hear these presentations live and to get a response from your questions right away. But also I want to remind everyone that today's webinar, as well as ones in the past, are then at a later time stored on the PNA website, and at any time you or your family or friends can go and go back and review what has been said, and these are kept as a valuable member benefit along with the other member benefits for the PNA. We have a wonderful store where you can purchase books and other items. You can make donations that help other people down the road. So please take a look at our website and our storefront as well. We have a highlights newsletter that comes out. That's a member benefit, and certainly the website provides so much up-to-date information. I certainly don't want to take any more time with all of that, but I certainly want to point that out to everyone. So without any further ado today, I certainly want to begin by introducing our phenomenal presenter. Dr. Lewis Blevins is the Medical Director of the Center for Pituitary Disorders at the University of California, San Francisco. His main clinical interests are in the evaluation and management of patients with a variety of disorders of the pituitary gland and the hypothalamus. He has particular expertise with regards to Cushing's syndrome, and he's edited a book on the subject. He also has extensive experience in treating patients with acromegaly, prolactinomas, and other pituitary tumors, diabetes insipidus, and hypopituitarism. He has extensive experience in the management of patients with growth hormone deficiency as well. His current research interests involve diagnostic testing in patients with hypercortisolism, and he is currently evaluating new ways to test for the presence of Cushing's syndrome. He's interested in clinical predictors of surgical and medical success with regards to the management of patients with different types of pituitary tumors. Some of his work involves collaboration with neuropathologists at UCSF. He's also involved in the industry-sponsored trials to evaluate new pharmacologic therapies for patients with pituitary tumors. He's also, by the way, an accomplished painter, and hopefully we'll see at least a little bit of his work here today. Without any further ado, I certainly want to thank on a personal level Dr. Blevins' responsiveness and very long support of the PNA. So please welcome Dr. Lewis Blevins.
Hi, good day everyone. Thank you for joining us today. It's my distinct pleasure to be able to present to you today. And I guess, Linda, if you could tell me, can you folks see the screen yet? Is that up and running? Just a confirmation.
I need to confirm with him. I need to get back to him. Okay.
Can you see the screen?
I have to tell him. Yes, Dr. Blevins.
Great. That's what I wanted to know. So at any rate, today I'll talk to you about Cushing syndrome, and I want to give you one of the presentations that I give to physicians because I don't underestimate the intelligence of patients. I think that my experience, Cushing's patients are often some of the most informed about the diagnosis and its treatment, so I want to share with you what I share to doctors. I've taken a couple slides out for length purposes, so we'll have some time to talk at the end. And I also want to pitch this to patients as well, so who may not have medical degrees or nursing degrees or what have you. So hopefully there'll be something here for everyone, and we can clarify anything that's not straightforward at the end. So most of you who have Cushing's or know people with Cushing's have probably seen these types of physical features. They're different patients with very severe forms of the disorder. It's almost uncommon to see this today. We do see it every once in a while where patients have the morbid central obesity and the stretch marks and the hair growth that you see and the severe bruising. But I would have to say that in the past 25 years that I've been doing patients with pituitary disorders in my clinic, we see this less often now than we used to. And that's a good thing, because I think that people are better informed, physicians are better informed, and patients are getting to health care sooner. However, we still see this, but it's the exception almost rather than the rule. Cushing syndrome is characterized by central weight gain, rapid weight gain. The skin literally becomes catabolized or torn down or broken down by the hormones cortisol and becomes very thin and paper-like and can stretch, and then since it's so thin, you can see the blood vessels through the outer layer, and that's why the stretch marks are often purplish like this second picture is shown. But they're not always that way. Sometimes they're slightly pinkish. It just depends on how fast and how severe the disorder is. You can see the one patient in the middle picture with acne and excessive hair growth and thickening over the fat pad on the back of the lower part of the neck and also above the collarbones. We call those the cervicodorsal and supraclavicular fat pads respectively. Some people refer to them as a buffalo hump, for example. And then the easy bruising is because the blood vessels are fragile. In the lower panel is a child with Cushing syndrome, and children will generally stop growing in height but gain weight, and that's and sometimes get depression, and that's what we'll often see in childhood with the particular disorder, and it can often be mistaken for just a child that's, quote, lazy, unquote, or doesn't get away from the table and eats too much, for example. So these are the many faces of Cushing syndrome, if you will. This is a list of some of the symptoms and signs of Cushing syndrome, and as most of you know, it can be associated with all sorts of different things, and that often makes it a difficult diagnosis because people will show up with diagnosis of hypertension or with diabetes or what have you, and the physician in management simply treats the hypertension or the diabetes or talks about weight loss programs for obesity or treats the osteoporosis, for example. And what we call a syndrome is a disorder where there's a constellation of a number of different features that you have to put them all together to come up with the underlying thing. So it's not just hypertension and not just diabetes, but it's hypertension and diabetes due to an underlying problem. And that's what a syndrome is. This slide has all sorts of things that we see in Cushing syndrome, but the ones that are the most predictive is the weakness, especially in the proximal muscles, premature osteoporosis, reddening of the face, and then the widened purplish stretch marks. Those are the ones that are said to have the highest predictive value of having Cushing syndrome. But again, that's data from the 1970s. In the latter part of this last century and in the 2000s, we certainly would argue that that's not the case anymore. This was an interesting study that showed the prevalence of Cushing syndrome was 3.3% in 90 obese, non-Cushingoid, poorly controlled diabetic patients. There was a recent study published that I saw last week showing that it was about 1 to 2% of poorly controlled diabetic patients. The point being that some patients with Cushing's come to medical attention through these other avenues, and these articles sort of remind physicians that it's important to consider what might be the underlying cause of diabetes rather than looking at it as just diabetes mellitus. These are the big ones. So in my experience, people who've had a rapid weight gain. So we're talking about 30 or 40 pounds over a very short period of time. And we're talking about a lot of weight gain, so that I've had patients who have literally doubled their body mass. The weight is redistributed largely centrally, so people have skinny arms and skinny legs, but very thick midsections and thickness around the face and the neck. That sort of a pattern or profile is very common in Cushing syndrome. Premature osteoporosis, especially in men. Less so in women, but especially in men. We think about maybe there might be Cushing syndrome. And then what we call proximal muscle weakness. And proximal muscles are those around the hip and the shoulder, so that people have trouble holding their hands to their head to do their hair or getting up from a chair, for example. And then the stretch marks are the other issues that we've already talked about, the widened purplish ones especially. Psychiatric manifestations are very common, and many patients that I've seen have presented with depression or psychotic features and been treated for 6 months to a year, refractory to treatment, and then an astute clinician notices, well, maybe you have Cushing's because you've gained all this weight and your face is red. And the other thing is diabetes and hypertension and hyperlipidemia are common, and those are more common in patients with metabolic syndrome than probably the most common thing in this country to see it as metabolic syndrome. But it's interesting. We see people who have diabetes, hypertension, hyperlipidemia with one or more of these other things, and it's important for physicians, I think, and patients who are seeing their physicians to say, hey, wait a minute, could all of this be caused by one problem? Rather than have 5 or 6 different problems. So sometimes you have to be a lumper instead of a splitter and lump everything under one diagnosis rather than splitting it into 5 different diagnoses. One of the most important things in the evaluation of someone thought to have Cushing syndrome is to not put the cart before the horse, because the horse can't pull the cart if it's in front of him. And what I mean by there is getting ahead of yourself. Someone often referred to this, or once referred to this as letting the train go down the tracks without someone paying attention to the brakes. And it's very easy for that to happen in Cushing syndrome because of several things. One is patients want answers, and patients often go to the literature and decide that they want particular tests to look for Cushing syndrome. And then the other thing is doctors are busy and frustrated and often don't have the time to think about a rational, logical, stepwise approach to the evaluation and management. And what happens is you start getting MRIs and CAT scans before you get tests that even confirm that you have the diagnosis. So it's important to go through a series of steps. Now, unfortunately, 20, 25 years ago, we admitted people to the hospital to do this workup. Now it all has to be done as an outpatient. Instead of getting it done in a week or 2, it can take 6 to 8 or even 12 weeks sometimes to get through and navigate through this list of testing, and that's just the way the human body is and the way medicine works today. It's very frustrating to us. But I think it's important to think of screening tests first, then diagnostic tests, then establish the ACTH dependency, and then go through differential diagnostic tests. And I'll go through some example of those here in a moment. So screening tests are tests that are designed to pick up a disease, and they're usually designed to pick up everybody who has the disease at the expense of maybe capturing a few people with positive tests who don't really have the disease. So these are best used for screening a large population, so maybe your uncontrolled diabetic patients or people in a weight loss clinic, for example. When it's pretty clear that somebody has Cushing syndrome, you don't do screening tests, you do diagnostic tests. But at any rate, these are the most common screening tests available today. The overnight 1 milligram dexamethasone suppression test, where you take dexamethasone at bedtime, you get a cortisol at 8 o'clock in the morning, a 24-hour urine cortisol, and then a midnight serum cortisol. This is a test where the overnight 1 milligram test was done, 203 patients over a 15-year period, and you can see here the number of Cushing's cases who fell in to the different levels of cortisol, so that cortisol levels greater than 10 after the test were seen in about 50 of the cases that were reported in this literature. And then you can see down here, the lower the cortisol gets, maybe the lower the number of cases seen. But the important thing is that in this test, we consider a cortisol level used to be less than 5 to be normal, so that normal people would suppress their cortisol less than 5, Cushing's patients wouldn't. And now the new criteria are to less than 2. So you should suppress your cortisol to less than 2 if you're normal, greater than 2 if you're abnormal. But you can see here that they had about 8 patients who had suppression of cortisol to less than 2 who still had Cushing's, and then probably another 5 who had cortisols between 2 and 3.5. And what this really says is that no test is perfect. So you can't diagnose Cushing's based on one test. You have to have a combination of tests, and you have to have an observant, capable doctor, he or she having seen a lot of patients with Cushing's and knowing exactly what they're dealing with. In regards to the urine-free cortisol, levels can be normal in some patients with Cushing syndrome. One of the first patients I diagnosed as a fellow was a lady that had a high normal urine cortisol, but had mild clinical features and hyperlipidemia and hypertension and gastritis and depression, and she ended up having a 1 centimeter pituitary tumor producing ACTH, even though her cortisol was normal. The thing was is it was too high for her, even though it was still in the normal range, because her normal might have been 25 and her levels were 50. And I think at that time normal was up to 80 in the lab. But we cured her with surgery and all of that. But when we look at urine cortisol levels, we think of levels that are 3 to 4 times over the upper limit of normal as probably diagnostic of Cushing syndrome. Anything less than that needs further study. Cushing's is unlikely if the results of 3 separate urine collections are normal. I've seen a lot of people sent to me, thought they had Cushing's, but every urine cortisol they ever had was normal, and usually they prove not to have Cushing's. So, but further study can be done to sort of confirm whether they're normal or abnormal. We'll talk about that in a minute. This slide shows you, if you will, on the y-axis, or the one going up, the levels of urine cortisol, and then different disease states that cause Cushing's on the x-axis, or on the horizontal bar there. And you can see the dotted line at 100, and that's sort of the percent of upper normal value, and it shows you a number of people here with Cushing's disease where you have a pituitary tumor or adrenal adenoma where there's an adrenal tumor, have cortisol levels that fall below that 100 line, and that sort of shows you the proportion of people who can have Cushing's and yet have a normal, put that in quotes, urine cortisol. So we do see this. Midnight salivary cortisol levels are sort of all the rave these days. The problem is a lot of them aren't done in reliable laboratories, and you have to make sure that you're getting it done by a lab that knows what they're doing. I don't like the midnight salivary cortisol level as a standalone test. I think of it as a screening test and not a diagnostic test. And you can see here that basically there's a lot of overlap is the thing to show you. If you look at the lower part of the graph, you can see in this lower area here a lot of overlap between people who have Cushing syndrome, pseudo-Cushing state, healthy volunteers, and control patients. So this test is not perfect either. It's a screening test. It's designed to pick up everybody who has Cushing's, but it's also going to pick up some of these people who don't have Cushing's. So a positive test for a screening test does not mean you have disease. That's the thing to keep in mind. A positive screening test means that you might have the disease, but you certainly need further workup. When it comes to diagnostic tests, which is sort of the next level up, we're looking for a test that has a little bit more power, if you will, to resolve normal from abnormal. And again, the urine cortisol that I mentioned is one of those tests, especially if the urine cortisol is somewhere between 2 to 4 times the upper limit of normal, or 3 to 4 times the upper limit of normal. You may have heard of the formal low-dose dexamethasone suppression test that was first published on in 1961 or thereabouts by Grant Little. It has gone through several different evolutions in testing, and the basic premise of this test is that if you give a lot of steroid, you will turn off ACTH and thus cortisol production in normal people, but you'll only turn that off in some people with Cushing's, and to different degrees depending on the type of Cushing's that they have. The goal there is to try to turn it off in normals, but you don't turn it off in abnormals. But it turns out about 20% of people with Cushing's will suppress with that test as well. So that led to the development of the dexamethasone suppressed CRH stimulation test, and CRH is now difficult to get, but it's a test that sort of picks up those people who are turned off by high doses of steroids, and it can help discriminate those from normal people. And then there's what I like to refer to as the salivary cortisol profile, and I'm the only one I know doing this crazy nonsense, but it's probably the best test for Cushing's, and I just need to publish on that one of these days. And I'll talk to you and show you a graph of that in the future part of this presentation. With regards to the low-dose dexamethasone suppression test, Jay Findling in Milwaukee showed that about 16.7% of patients with Cushing's had an abnormal test result, or a normal, quote, normal test result. In other words, they would have been classified as not having Cushing's when they did. So again, this fits into the scheme of no test is perfect, and you need a good doctor who can help navigate all the test results. With the serum cortisol to less than 1.8, there were 3 of 150 people who would have been classified as normal. So again, no test is perfect. I'm going to skip through that slide. So this is an example of the salivary cortisol profile that I do in my practice, and you can see that we can get 3 salivary cortisols in the morning, 3 in the afternoon, and 3 late at night. And this is a normal profile. Cortisol is a hormone that's secreted according to our sleep-wake cycle, so that your morning, regardless of whether that's 8 o'clock or 11 o'clock at night, depending on your sleep cycle, at your morning after you awaken, cortisol levels are highest. In the afternoon, they are half of what they are in the morning, and at bedtime they're usually about 1/5 to 1/10 of what they are in the morning. So the levels rise and fall, and day after day this looks like a nice little wave going up and down. And in this other panel, figure 1B, you see a patient that has Cushing's disease, and this was a patient who actually had pituitary tumor and had surgery and was thought to be cured, and then like 3 years later comes into my practice and says, I just know my Cushing's is back. My urine cortisol is normal, but it's gone from 20 to 45. I'm not sleeping. I'm gaining weight. I'm feeling all the same things I had before. And we did a salivary cortisol profile on her, and you can see that she has lost that diurnal variation of cortisol production. And the levels actually were sort of erratic and basically flat throughout the 24-hour period, maybe even a little higher towards the evening. But this loss of this normal diurnal wave that we see is probably the best predictor of whether someone has Cushing syndrome. So we do this a lot in our clinic. If we see someone who maybe has equivocal test results that aren't making sense and we're not sure if they have Cushing's, I will do this test and I can tell whether you have Cushing's or not based on this particular test, doing non-salivary cortisols. Once we figure out a patient has Cushing syndrome, we have to figure out where the problem is. And this is basically what we call the differential diagnosis. In other words, is it a pituitary tumor or an adrenal tumor or adrenal hyperplasia or a tumor somewhere else producing ACTH? And a lot of times physicians sort of start on this part of the process before they confirm the Cushing syndrome. And this is the part that gets really expensive with MRIs and CAT scans and things like that. So it's important to try to not put the cart before the horse for a lot of different reasons. One, because some of these tests are invasive. Two, because they cost a lot of money and you don't need them if you don't really need them. But this process starts out getting an ACTH level. If it's normal or high, that means it's a pituitary problem or a tumor somewhere else producing ACTH. If the ACTH is low, usually less than 10, that means the adrenal glands are the problem. And obviously if it's a pituitary, you scan the pituitary gland. If it's the adrenals, you scan the adrenals. And that's why the radiological studies have to be done based on the biochemistry. Sometimes we can do a high-dose dexamethasone suppression test if we want to try to figure out whether it's ectopic ACTH or pituitary tumor. And then there are other laboratory tests if we think it's ectopic, like we might screen for a tumor called a carcinoid tumor or a tumor called a pheochromocytoma. Probably the best guide to the differential diagnostic test is a physician's intuition, and you can't develop an intuition unless you've seen a lot of patients, and it fits into what I refer to as the art of medicine. It's interesting, as a physician, you go through the part of your training where you're learning a lot of facts, and they're not really based on literature. It's sort of the way it is, because that's the body of knowledge of medicine. And then you go through this phase of what we like to refer to as evidence-based medicine, where you start making treatment decisions based on evidence. And then if you've been doing this for about 20 years, you start realizing that a lot of what you do is the art of medicine, where your patients over a 20-year period or so, in my case almost 26 years, have taught you far more than any book and any set of papers that you've ever read. And that's where the physician's intuition comes in, the art of medicine, and that's why it's good to go see doctors who are experienced and have a little knowledge about what's going on. And with all due respect to my colleagues, going to see a regular endocrinologist for Cushing's is probably a waste of your time. You need to seek out a pituitary specialist to see someone who has developed that intuition about the diagnosis. Patients who have high ACTH or normal ACTH levels usually have pituitary tumors or ectopic ACTH production, rarely pituitary hyperplasia, which we won't go into today. And then those who have low ACTH levels have one of a number of different adrenal disorders, adrenal cancer, benign tumors, or enlargement of both adrenals, or they've been given exogenous steroids. And I've seen plenty of people who referred to me for Cushing's, and it turns out that they've been getting injections in their spine for steroids, or in their knee or their hip or what have you. And even one who was using a lot of steroid cream to treat psoriasis, so developed Cushingoid symptoms and signs. So exogenous steroids are the most common cause of Cushing's in society. if you're walking through the mall and see someone that looks Cushingoid, they're probably taking steroids. It might be someone with pituitary tumor, but it's probably someone taking steroids. And this is sort of the thing that interests me the most about Cushing syndrome, is that patients who really have Cushing syndrome are often misdiagnosed. The average diagnosis takes 2 to 5 years, and I've seen it take up to 20 years. But physicians see people with Cushing's all the time because they're treating asthma or skin disease or rheumatologic conditions with high-dose steroids, and they're used to seeing Cushing syndrome. But when the patient who's not on steroids comes in with all the same manifestations, it's almost like they have a blind eye or an eye turned away from it. And I can't figure that out, why the human brain works that way. But it does, and unfortunately, even though physicians know Cushing's because they've treated patients with steroids for high doses for different reasons, they miss those who have pituitary tumors and adrenal tumors. It's rather curious. So this is an example of a couple of MRIs showing pituitary tumors. On this panel, I'm not sure if you see my pointer, but there's a very small dark thing on the left of the pituitary gland, here being the pituitary, this being the tumor. And in this panel, this is a tumor that's huge and has invaded the cavernous sinuses and the floor of the middle cranial fossa here in this patient with an invasive tumor. Most of the time MRI can pick it up. This slide was done years ago where it's thought that MRI was unrevealing in 20% to 30% of patients who had pituitary tumors causing Cushing's, but we now believe that it's probably a little better than that. Maybe you miss 10% with the modern MRI capabilities. What we see in our practice sometimes is people who are thought to have Cushing's, they have the biochemistry of it, the abnormal test results, the clinical features, and they have an MRI that didn't show any tumor. And it was sort of the wrong MRI. So we'll do an MRI here, and we like to do them with dynamic contrast enhancement. We can actually follow the contrast and the blood flow through the pituitary gland and get good separation between tumor and the normal pituitary gland. So the type of MRI you have is critical. The thickness of the cuts is critical. And we believe that we probably see most pituitary tumors with MRI at our institution and rarely have to resort to what we call inferior petrosal sinus sampling, which is what I'll show you in a moment. Ectopic ACTH secretion is the secretion of ACTH by tumors outside of the pituitary gland, and basically they can be neuroendocrine tumors that are located anywhere in the bronchial tree, which is the airway passages in the lungs, is probably the most common, but they can occur in the thyroid gland, the pancreas, the adrenal glands, and basically in any body tissue. And the most common ones that mimic pituitary Cushing's are in the lungs. This is a schematic showing you the Petrosal sinus sampling, so that if we have a patient that has Cushing's but no radiological evidence of a tumor, and we know it's producing ACTH, and the biochemistry doesn't sort of illustrate whether it's a tumor in the pituitary elsewhere, we can actually take very tiny wires and catheters or little tubes and pass them through your groin, all the way up through your body, through your heart, into your head, and sample blood from the pituitary gland and your arm vein, and then do some mathematical calculations and determine whether or not the tumor is likely in the pituitary or somewhere else. And this is a useful test, but we rarely have to do it around here because our MRI scanners are so good. Probably we do 2 or 3 a year, though, I would say, but that's certainly a very small fraction of the patients that we're seeing with Cushing's. One other test that can be useful is an octrea scan or an octreotide scan, and sometimes PET scans, positron emission tomography, and we can pick up the neuroendocrine tumors that way. This is a scan showing the tumor in the lung of a patient who had had 2 prior pituitary surgeries when they thought that he had Cushing's due to a pituitary tumor, and it turned out it was in his lung. These are some examples of adrenal tumors and cancers and hyperplasias. I always try to remind people that the adrenal gland not only responds to the ACTH produce cortisol, it can develop a tumor and produce cortisol on its own. And then there's some very, very rare disorders that lead to adrenal hyperplasia where both glands are involved and can require special treatments depending on the underlying disease process. Subclinical Cushing's is a term that you might see, and this is a situation that's most often due to adrenal tumors, but I have seen it due to pituitary tumors as well, where the cortisol production rates are very, very, very mild and still within the normal range. And then the spectrum of abnormalities is that they'll have altered salivary cortisol profile or failure to suppress with dexamethasone. That's just it's a term that's out there in the literature that I wanted to throw out. The other term that I don't have a slide here is what we call periodic hormonogenesis or cyclical Cushing syndrome. And I will have to tell you that in 25 years of doing this, that's very, very rare. Cyclical Cushing's, I've seen maybe 2 real bona fide cases in 25 years. I've seen a lot of people who were told by various physicians that they thought they had cyclical Cushing's, but they turned out not to have Cushing's at all. And one of the things I want people to try to avoid is thinking they have Cushing's, hearing that they might have Cushing's, but the test results coming back normal, and then hearing, well, maybe it's cyclical Cushing's, and going forward and believing that what they have is cyclical Cushing's. I think that repeated workups will prove that, but I far and away have seen 10 times to 15 times more people who were told they had cyclical Cushing's but didn't have Cushing's at all than I have seen people who actually had cyclical Cushing syndrome. The objectives of treatment of Cushing syndrome are to try to correct the syndrome by lowering the cortisol secretion to normal, eradicate any tumor, whether it be in the lungs or in the pituitary, that might threaten the health of the patient. We like to try to do this by avoiding endocrine deficiencies, so you really want a surgeon who can operate on the pituitary without causing further damage. We want to avoid permanent dependency on medicines, whether they be pituitary hormone replacement medicines or whether they be medicines that are designed to treat the Cushing's itself. And then we also, in this day and age, are able to treat the comorbidities such as the infections, the hypertension, the diabetes, and the high cholesterol. Cushing's used to be thought of, and still is, a fatal illness, but it's less fatal than it used to be. Back in the 1970s, the 5-year survival of untreated Cushing's was 50%. And I would say that it's probably 5-year survival of untreated Cushing's is probably 95% now, because we have medicines to treat all these comorbidities and other complications of the disease process. Generally speaking, if you go to a pituitary center of excellence, you can expect a cure for microadenoma of Cushing's in about 85 to 90% of the time, with recurrence rates of 10 to 15%, and macroadenoma should be cured about 2/3 of the time, with about 1/3 coming back over time. The most important thing I can say is pick your surgeon very carefully. You really, truly want to go to an experienced neurosurgeon in a center of excellence, and that's because the first attempt is often the best chance for cure when it comes to Cushing's disease, and really any type of pituitary tumor. This slide shows, oftentimes physicians will check post-operative cortisol levels, so before the patient goes out of the hospital, they'll check the cortisol level and determine whether or not the patient's cured. And basically this is a series that we published looking at all the different data in the literature, and the bottom line is that of those patients who end up having an undetectable cortisol, 8% will still have recurrences. So I tend not to put a lot of faith in early diagnostic testing, and most of the best testing is done between 6 weeks and 6 months after surgery. There's no reason to expect to know the day of surgery or even 6 weeks later whether you're cured or not, because you're either cured or you're not, and you'll know soon enough. I've seen recurrences as long as 14 years after initial successful surgery, so we like to think of it more as being in remission than being cured, and just keep that in mind. So there's no hurry to find out what the lab results are. There's no hurry to rush back to surgery if your cortisol levels are not undetectable, and even if they are undetectable, you still may not be out of the woods. One of the things, this is a slide, I show this, basically it's a complex slide, but it's called Kaplan-Meier survival curves, and it's if you follow people over time or months after surgery on the lower part, and then look at the free survival. Basically, you can see 3 different groups here. The top group that has 3% shows that 3% of people with undetectable cortisol levels recurred in this study. The middle line is people that had cortisol levels that were, quote, normal, unquote, and it showed that only 50% of those recurred over a 10-year period. So having a normal cortisol after surgery doesn't mean that you're going to have a recurrence, because only half the people will. So I like to show that just to keep that in mind as well. It takes time for the dust to settle to figure out what's going to happen in the long term. There are a number of different causes of patients having failed surgery. One of them is incomplete or failed tumor resection, and it's important to keep in mind that a number of these tumors actually microscopically invade surrounding tissues, whether it be the normal pituitary or the bone along the pituitary socket known as the sella turcica. And it's been shown that 8% of the small tumors are invasive and 62% of the large ones are. And in this slide, this patient had a tumor that was invasive into the brain but we still wouldn't call this a malignancy, even though this tumor had invaded the bone and compressed the brain. If this were a thyroid tumor or a lung tumor invading bone and compressing another organ, we would call that a cancer. But why didn't we call this pituitary tumor a cancer? I don't know. This patient actually died of this tumor 15 years after that MRI was done. So to me, that's a cancer. It was an invasive disease, and it claimed the life of the patient. So that we as physicians have to figure out what do we define as a malignant versus a benign tumor. But the bottom line is some tumors are invasive and they can't be cured. Sometimes the tumors are so small and they can't be seen, and we know that the failure rate of surgery is higher if the MRI did not show a tumor and the surgeon had to go in and explore. And of course, if there's no tumor found on the tissue resected, the failure rate is higher as well. Sometimes the diagnosis before surgery was incorrect. I've seen patients who came to me, as one I showed, who had ectopic ACTH production from lung tumors, but had already had pituitary surgery and of course weren't rendered disease-free because they were operating on the wrong place. Some patients have pituitary tumors that are near the pituitary but not in the pituitary, like on the pituitary stalk or in the cavernous sinuses. Some people have a rare disorder called corticotroph hyperplasia, and then some people don't have Cushing's at all. They have pseudo-Cushing's, or they've been given a false diagnosis and they had a pituitary exploration and nothing was found, and we certainly see that as well. And then I have, believe it or not, seen a couple of cases of factitious Cushing's where people were taking steroids mimicking the illness and snookered a few physicians into believing they really had Cushing. So clearly those people weren't cured by surgery either. For people who aren't cured by surgery, there is radiation treatment that can be given, and that's often used in Cushing's, maybe not so much in some of the other pituitary tumors anymore, but still used widely in Cushing's and maybe some acromegalic patients. And there's two forms of radiotherapy, the stereotactic radiosurgery and the conventional radiotherapy. And on this slide you can see that we like to use the stereotactic if it's an identifiable lesion on the MRI and there's an opportunity to treat without injuring the visual pathways such as the optic nerves, optic chiasm, or optic tracts. Conventional radiotherapy is more often used for patients who have widespread inoperable or invasive disease and lesions that are close to the visual pathways. Generally speaking, the best results are about 50% of people will enter remission. This Estrada paper showed 83% entered remission. That's the best results that have ever been done and published. Most people will say that you get about 50 to 60% of people entering remission with radiation. And you can see that it can take anywhere between 6 months to several years for the cortisol levels to normalize after getting radiation. Generally speaking, if they're not normal by 5 years, I consider the patient to be a non-responder. So a patient may require additional treatment, such as medications to control the Cushing's, for anywhere between 6 months and 5 years after radiation, or long-term if the radiation hasn't worked. There used to be a lot of drugs that we could use, dopamine agonists, serotonin receptor antagonists, octreotide, PPR gamma agonists have been tried. Aminoglutathamide used to be available. It's no longer used. Metyrapone is still available but difficult to get. We're really left now with one steroid biosynthesis inhibitor known as ketoconazole, and there's a recently approved glucocorticoid receptor antagonist, mifepristone, which blocks cortisol action on cells, and then another recently approved drug, pasriotide, which is similar to octreotide used in acromegaly, but can also inhibit cortisol production and probably control about 27% of patients with Cushing's or so. So we have medical therapies that we can use for people who are not candidates for surgery, radiotherapy, or while we're waiting for those other drugs to work. Bilateral adrenalectomy is something that the top quote is something that I wrote about a long time ago. Adrenalectomy should only be employed as a last resort when all else has failed and the patient is in grave danger due to the consequences of hypercortisolism. But now, I say, based on a lot of articles that have come out, that the success and relatively low risk of complications of laparoscopic bilateral adrenalectomy require that we reconsider our attitudes towards adrenalectomy in patients with hypercortisolism. I still believe that taking the adrenals out, especially both of them, where you're basically trading Cushing's and adrenal insufficiency, trading one disease for another, I think it should be used very judiciously, very cautiously in patients and with Cushing's disease or ectopic ACTH, when it looks like nothing else is going to work to control the disease process. I think the timing is critical. If you do it too soon, you might miss an opportunity for some other therapy to work. If you do it too late, it may not benefit the patient at all, who might succumb to their illness. It is associated, even though the Mayo Clinic has reported no mortality, we see mortality in response to this procedure. So, blood clots after surgery with pulmonary embolism. Saw one patient who had hemorrhage and went into shock, was Jehovah's Witness and didn't want blood, and died as a consequence of just this slow tissue hemorrhage because the tissues are fragile in patients with Cushing syndrome. So nothing is free. Everything has a risk, and even though there's a paper that says there's no mortality, guess what? There can be mortality. So you have to be fully aware of the risks of even this type of procedure. Patients with Cushing's often want the most rapid cure. This is the most rapid cure for the Cushing's, but it doesn't often treat the underlying tumor. But it is truly the best way to get a hold of the Cushing syndrome. But again, you are trading for adrenal insufficiency, where you're permanently dependent on 2 different medications and salt intake to survive. Obviously, if a patient has adrenal Cushing's, we take out the adrenal tumors, and then we take out both adrenals if they have hyperplasia, because there's no other treatment. Adrenal cancers can be treated with different chemotherapy regimens. I refer my patients with adrenal cancer to MD Anderson Cancer Clinic, where they have probably, or David Steingard at the University of Michigan, where those 2 centers have the greatest experience with chemotherapy for adrenal cancer. I think the summary slide here is an important one, and it's more nebulous and really speaks to sort of the art of medicine and what medicine's all about. And the first thing is a close doctor-patient relationship is essential. Patients with Cushing's are not your patients who come in and get their well visit check or maybe get their hypertension drug renewed. They have issues that need to be tended to. You have to worry about tumors and hormones, and then secondary hormone consequences, and psychological manifestations, and it's truly a disease that affects the family more so than, say, hypertension does, where the patient feels fine without symptoms. So there's often family counseling and sort of a, quote, family practice approach, unquote, if you will, involved in these patients. I think it's also important to recognize that decisions regarding treatment must depend on clinical, in other words, what we see, biochemical and radiological findings, and the level of expertise of the treating physicians. So you have to sort of base it on real findings, your decisions about treatment. And you also have to base that on how good the physicians are. So, for example, I would rather my cancer patients go to MD Anderson. My surgeon, I think, is the best in the country, so I'm going to let him operate. Our radiation oncologist people are excellent as well. But you may be at a center where they don't have a good radiation oncologist, or where they have a tremendous oncologist, or where the pituitary surgeon has only done a fraction of what he should be doing. So decisions about treatment have to depend on what's available in the physicians and also what the test results show. I also think it's important that patients be permitted to make informed decisions regarding available treatment options. So we spend a lot of time talking about we could do these certain treatment options, and here are the outcomes, and here are the consequences of therapy, if you will, the adverse effects. And then patients need to know what their choices are, because the patient's the one with the disease and has to live with the disease, its treatment, and the consequences of treatment. And I think that's just good medicine to educate patients and help them make decisions. Now, it may be that I'll have a favorite choice for them, or I'll come across with a strong recommendation, but the patient is the one with the disease and has the ultimate say-so on what we're going to do, provided that it's medical or medically justified and appropriate, obviously. The other thing is that lifelong follow-up is essential, so it's not one of those things where you quickly get your test results showing you're in remission and you go on your merry way. You have to see the physician at least annually, certainly every 6 months for the first couple of years, to sort of sort out the biochemistry. But you need to submit a urine cortisol once a year for life, and anytime you feel like your Cushing's might be back, because the recurrence rate is 10 to 15% for the small tumors and 33% for the larger tumors, and those recurrences can come 14 years later. So you have to be followed for life. And then there are other consequences too, growth hormone deficiency that needs treatment, or or other hormone deficits that may need attention. Some of the long-term consequences, such as the depression and memory, don't always go away after treatment of Cushing's, and atherosclerosis can be a problem as well. So you have to stay in tune and in touch with your doctor. And then the last thing, obviously I'm biased because I am at a tertiary medical center, but I think that serious consideration should be given to referral to a tertiary medical center for advice and management, especially for Cushing's, but also for basically any type of pituitary tumor, just because that's what we do for a living. You know, you don't take your car to a brake man to get the transmission changed, even though the brake guy may know a little bit about transmissions. You take it to the transmission expert. You don't take a German sports car to a Ford motor car dealership to have the engine repaired. You take it to the German sports car dealership to have that work done. And why not do the same thing with our bodies? And the other thing is that the world is much smaller with airplanes and rail travel and all sorts of other ways to get around, and those things are still relatively inexpensive, and the costs of surgery elsewhere can be rather large if things don't go well, especially if you're not cured. So you might as well go to some place where you think that you can be rendered disease-free. Just last week I heard about a patient who had inquired about coming to our center, and given the situation we suggested that maybe they should come. And maybe it's 2 weeks ago now, and that person elected to stay at a local facility and had an operation that resulted in blindness and no removal whatsoever. The tumor now requires a second operation, and that's what we want to avoid, is the disasters. So we're not the only tertiary medical center. There's a lot of tremendous neurosurgeons in this country and some grand endocrinologists as well, and I recommend that you find one and get the very best care possible. And I apologize, but I forgot to add a painting. I was asked to add one of my paintings to the end of the presentation, but you can look at my website if you'd like, if you want to see some of those. It's www.ca for California, capaintings.com. And the title of the website is California Paintings, so if you just put that in the Google search, you'll find it. But at any rate, I appreciate the opportunity to have presented to you today, and I would be happy to answer any particular questions that might have arisen as a result of this nonsense I've been spewing for 45 minutes. So thank you.
I don't believe it was nonsense at all, Dr. Blevins, but I am disappointed that we don't get to see your paintings. So, but thank you very much. Just a wonderful presentation. That's okay. I really do understand.
The paintings are on the website.
Yeah.
So the paintings are on the website, and I also have a blog. So if you want more nonsense, you can go read.
Well, we have a lot of non-nonsensical questions, a ton of questions, and I think we'll just get to as many as absolutely possible. One that fascinates me, has any further research been done with zebrafish to help reduce cortisol in Cushing's?
You know, I have to admit that I'm not following that area very much. I'm more of a clinical researcher and clinical endocrinologist, and I don't do that translational research, and there's so very much to learn and to try to keep up with that I haven't been following that literature very well. So I have to plead ignorance. So
well, we are all ignorant about something, so thank you for acknowledging that. You mentioned...
And the other thing I'll tell you about that, if you have a doctor that doesn't plead ignorance, you're seeing the wrong doctor. So you want someone who knows their limitations. So that's important to keep in mind as a patient. So
that's very honest. Thank you. I know you mentioned cyclic Cushing's, but we do have a question about how is cyclic Cushing's diagnosed. This person said that they've gone through stages, kind of like an on-off switch over the years, and it seems to change. You know, there's fatigue, muscle weakness. It seems to be the main problem. So can you briefly address just how it gets addressed?
Sure. In the two patients that I've had, basically both of them looked Cushing-like, but when we did the test, they didn't have high cortisol levels, and then their Cushing's would literally improve over a period of a month or two, and then 3 or 4 months later they would get Cushing weight again, and we would do a urine cortisol and it was elevated. So it's really sort of catching it, and the most important thing is to to do for the patient to have urine cortisol jugs at home, so that, or a quick access to get it from the lab, so that whenever the patient feels that he or she might have the disorder or have a recurrence, to go get the urine cortisol. And sometimes you have to do 10 or 20 of them. And then when you find them elevated, sometimes you have to figure out the periodic nature of it, because it is very periodic, so that people will get every 2 months or every 6 months or every 11 months or whatever. It seems to march through like that. There are several studies that have documented it, and the 2 patients that I've seen, one of them was about every 2 months, the other was about every 6 or 7 months. The cortisol levels would come up. They would stay up for probably about 3 weeks, and then they would come back down. The other interesting thing is that sometimes in between the cycles, the patient will have what looks like adrenal insufficiency. So it basically takes time, but you can catch it. And it's by doing the urine cortisols and sometimes doing the salivary cortisols at midnight as well that can help you catch it. It can be very frustrating, but it's there, you know. And the interesting thing is, my patient, we finally proved that she had cyclical Cushing's, but we couldn't find a tumor. So we ended up, because her Cushing's almost killed her a couple times because it got so severe, we ended up taking her adrenal glands out, and then 3 years later she developed a pituitary tumor that produced ACTH, sort of like a Nelson syndrome, but it took getting her adrenals out for that tumor to actually grow big enough to find. So it's real. It's definitely, I didn't used to believe that it was real until I saw my first patient. I thought, okay, now I get it. And I believe it's real, but I think it's sort of a catchphrase that a lot of people are told that that's maybe what they have when they really don't have Cushing's at all. So it's important to get that salivary cortisol profile, but to try to catch it with the urine cortisols.
I appreciate hearing that response myself. Here's a question about someone who has a 16-year-old daughter with adrenal insufficiency, Addison's disease, that was diagnosed last year, and Graves' disease also diagnosed last year. She's on medication, let's see, responsible for having Cushing's disease. What can I do to help her daughter? Reducing medication that is responsible is difficult, as she needs the dexamethasone 0.5 milligrams, which is already at the minimal level. She takes, let's see, 0.1 milligram of Florinef.
Florinef, yeah.
Florinef, okay.
Mm-hmm.
And it was recently increased from 1 per day to 2 per day. What questions should I be asking her doctor?
A couple interesting things. One is that the Florinef should be judged based on the potassium, sodium, and plasminogen doses, and whether the patient salt craves. So that's easy. And most children that age will require 0.2 milligrams a day. Adults require 0.1, and older adults require 0.05. So the dose decreases as you get older. And I'd say a 16-year-old 0.2 would be about the right dose. In regards to dexamethasone, my feeling is that a dose of probably about 0.25 to 0.375 is what we call replacement doses. And that patient may actually be receiving too much dexamethasone, especially if they're getting Cushingoid features in response to it. I did some studies at Vanderbilt in patients who have a related disorder called congenital adrenal hyperplasia, and to just make a long story short, that's a disease process that will help us understand what the body's requirements for steroids are. And we found that a dose of 0.44 milligrams was supraphysiologic, meaning enough to suppress adrenal function. So it stands to reason that a dose less than that, so 0.25 or 0.375, is what we would call replacement therapy in someone who has Addison's disease or no pituitary function. And I do like dexamethasone. It's the preferred steroid to treat people who have adrenal insufficiency in my practice. We find that 70% of our patients take 0.25 milligrams a day, probably 5% take 0.125 milligrams a day, or 0.25 every other day, and then the remainders are taking 0.375 milligrams a day. I have maybe 2 people taking 0.5 milligrams a day, but generally speaking, most people are on 0.25 to 0.375. So that patient might actually be overtreated with dexamethasone. And that's in part related to the fact that a lot of the old textbooks say that 0.75 to 1 milligram is, quote, daily replacement, unquote, and that's simply not true. So we know that the replacement dose is much less. So I would challenge the physician about that, especially if there are any Cushingoid features. And those of you out there with Cushing's who are taking dexamethasone because your adrenals have been removed or your pituitary is still suppressed from the long-term Cushing's, that dose of steroids is about right, 0.25 to 0.375. You're not going to recover pituitary function, or you're going to get continued Cushing-like symptoms if you're taking more.
Thank you. How would the results of an IPSS done for pituitary Cushing patients differ from one whose Cushing's was really caused by a lung tumor?
Normally in patients who have pituitary Cushing's, the ACTH levels coming out of the pituitary after the CRH administration are 3 times higher than the ACTH level in the peripheral vein. Now what we usually see is it's 10 to 20 times higher, so it's pretty obvious. ACTH levels will be 5,000 from the pituitary but 200 from the vein. But those who have ectopic ACTH, the ACTH levels are basically equal regardless of where the blood's drawn, whether it's from the pituitary, the peripheral vein, the leg, or what have you. So that's the way the test works. It's just you're sampling very highly concentrated pituitary blood where the ACTH hasn't yet mixed in the heart with all the blood from other parts of the body. So the Petrosal sinus sampling usually shows what we call the gradient of 3 to 1, 3 times higher than the peripheral vein, since it's coming directly from the pituitary and it's not mixed with the rest of the blood in the body. But since the tumor is coming from the lung, the blood there, and the pituitary is shut off making ACTH, so, and the tumor coming from the lung gets to the heart and mixes with all the other blood, so the blood from the pituitary and the lung are the same since the pituitary has had its ACTH shut off by the high cortisol driven by the lung tumor. So that's how we sort out whether it's ectopic or pituitary Cushing's.
Could you speak just briefly to why urine cortisol versus blood cortisol?
The blood cortisol is a reflection of the cortisol level for the 5 seconds that it takes that tube to fill up with blood. And that's a very small portion of our day, whereas the 24-hour urine cortisol is an integrated function of cortisol produced throughout the entire period of the day. So I think that a random cortisol is useless for Cushing's, but a urine cortisol is more useful because it represents integrated function and reflects the production throughout the day. And what we know about Cushing's is that the tissue changes and the disease state is caused by exposure to cortisol, not only the amount of cortisol produced, but cortisol during times of the day when you're not supposed to see it. So one of the reasons people with Cushing's have trouble sleeping, for example, is those of us who don't have Cushing's, their cortisol levels are extremely low when we go to bed and then don't start to rise until about 6 o'clock in the morning, whereas the patient with Cushing's is making cortisol throughout the day irrespective of time, so they can't sleep because their cortisol levels are higher than they're supposed to be at bedtime. So that blood cortisol in the morning in a Cushing's patient could be equal to a normal cortisol level for a person, but the blood cortisol at night might be much higher. And it's hard to ask somebody to drive into the lab at 11 o'clock at night, and the lab's not too happy when a patient shows up for outpatient testing at 11 at night. So the urine cortisol sort of overcomes all of that and gives us the integrated amount of cortisol produced in a 24-hour period. And I think it's far more useful and reliable. It's like if you have diabetes mellitus, you could check your blood glucose, but that's the 5 seconds it takes to get the blood. Or you could do the hemoglobin A1C, which reflects what your blood sugars have been for the past 3 months. So the urine cortisol is just like the hemoglobin A1C. It's an integrated measure of what's going on.
Thank you. Can you get secondary adrenal insufficiency several years after having a pituitary tumor removed, and could the scar tissue cause that?
I'm not sure if it's the scar tissue, but I think it might be. I have seen patients who've had pituitary tumors removed and then later, say a year or so later, diagnosed with secondary or central adrenal insufficiency. And one of my hypotheses is that it's probably scarring up of the blood vessels from the surgery, so that the blood flow to the pituitary is very complex and dynamic and comes from 2 sources, the portal vessels coming from the brain and the inferior hypophyseal arteries. Some of them go directly to the pituitary. And I think that what happens is that after pituitary surgery, you probably get, as you get scarring in the gland and all of that, you probably get traction on those vessels or occlusion of those vessels, and then that can result in pituitary dysfunction. So sure, I've seen that happen before, and that's my fantasy hypothesis as to why it happens or what might be going on.
Okay, we're really coming up on our time here, but I'll try to squeeze in one more. If someone has hypercortisolism or Cushing's, is it dangerous to receive steroid injections such as you would get with Kenalog?
It depends. Obviously, it'll make the Cushing's worse, but it might also treat the underlying disorder. So I had a call just not long ago, maybe 2 weeks ago now, by a patient who has Cushing's and had some kind of a problem. The doctor wanted to give steroids for him. My usual approach is it depends on what the diagnosis is, because Cushing's already is too much steroid, but we treat some illnesses with too much steroid and you get Cushingoid. So that if you had a life-threatening disorder or an inflammatory condition that definitely needed to be managed, like vasculitis or rheumatoid arthritis or Goodpasture syndrome in the lung or what have you, then yeah, it's probably worthwhile using the high-dose steroids even if you have Cushing's. But if you if you have a swollen knee, somebody needs to figure out whether it's gout, not just give steroids or something like that. So it depends case by case basis. So steroids can be used in patients with Cushing's. They often don't need them because usually Cushing's suppresses inflammation, and what we'll often see is someone has surgery for Cushing's and then afterwards they end up getting joint complaints, or I've seen a couple of people diagnosed with rheumatoid arthritis, another one diagnosed with lupus, another with thyroid problems after getting cure of the Cushing's, where we had lowered the steroids which were suppressing those other autoimmune disorders. So strange things do happen, but yeah, sometimes you need steroids and you should take them.
Well, thank you very much, Dr. Blevins. We have a lot more questions that we didn't get to. I apologize for that. You were so thorough in your presentation. I'm hoping that many of the questions were answered within the body of your presentation. And once again, we're very, very thankful to you. I would like to.
It's my pleasure.
Oh, so much. And I would make note to go and look at Dr. Blevins' artwork. It's really phenomenal. I do want to point out to everyone that we do have a whole series of presentations. Our next one is March 4th, entitled What to Expect Before, During, and After Surgery by Dr. Andrew Little. And then we have one on April 1st with Dr. Nelson Ioscu. And May 20th, we have Dr. Ron Swerdloff, who will be talking about reproductive hormone deficiency. And then we will finish up at least the first half of the year with Dr. Dan Kelly on endonasal endoscopic pituitary surgery. And I think all of those will be fascinating. So hopefully everyone will keep your eyes and ears open, looking for our announcements. And have a great rest of your Monday. And thank you again, Dr. Blevins.
You're quite welcome. Good day.